As we know, the major reason why a patient seeks a physician is for his pain. And it's important for the physician, therefore, to understand the mechanisms of pain so that he will be better prepared to deal with it. In this video, let us briefly consider pain pathways. Let us say you bump your shin on a table edge. You first withdraw your leg. Then there is a sharp pain shooting from the point of contact. This will be followed by a dull pain that lasts longer. That initial withdrawal was mediated by type 1 and type 2 fibers, which carry information at the speed of about 120 meters per second. The sharp localized pain, otherwise called as fast pain, is mediated by A delta fibers. They carry information at a speed of about 30 meters per second. And the dull diffuse pain, called as slow pain, is carried by the C fibers, which carry information at the rate of about 2 meters per second. Pain is defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Two systems are involved: a bottoms-up system, which includes the pain processing pathways, and a top-down system, which includes the pain modulation pathways. Free nerve endings, or the nociceptors, are the receptors for pain. They are found in every part of the body except in brain and spinal cord. Information is then carried by A delta and C fibers. A delta fibers are thinly myelinated and they conduct faster than the C fibers, which are unmyelinated. These fibers can be grouped as specific type, which are stimulated by any one modality like mechanical or thermal or chemical, or they can be polymodal type, which can be stimulated by more than one modalities. They can travel in spinal nerves if they are carrying pain sensation from trunk and the limbs, or they travel with trigeminal nerve if they are carrying pain sensation from head region. And pain efferents coming from the viscera generally accompany postganglionic sympathetic nerves. When these A delta and C fibers reach the spinal cord, either they rely on specific nociceptor neurons that are located in laminae 1 and 2, or they rely on the non-specific neurons located in the laminae 4 to 6. The non-specific neurons are convergent and polymodal, that is, they receive inputs from many areas and many modalities. As these non-specific neurons receive convergent information, both from viscera and somatic regions, they form the basis for referred pain, wherein the visceral pain is perceived to be originating from the somatic area. And as these non-specific neurons receive polymodal information, they form the basis for segmental antinociception, wherein the mechanoreceptor information transmission overrides the pain information transmission, which is classically demonstrated by rubbing the sore spot to alleviate the pain. Information, once it reaches spinal cord, it will be transmitted through either the neospinothalamic or paleospinothalamic or archispinothalamic pathways. They are named according to the evolutionary timing of their appearance. Neospinothalamic pathways are typical 3-order neuron pathways. They have fibers arranged somatotopically, and all the fibers in the tract are crossed fibers. Whereas both paleospinothalamic and archispinothalamic pathways are polysynaptic. There is no somatotopic organization, and they have bilateral projection. Neospinothalamic pathway tracts begin from specific neurons in lamina 1, whereas paleospinothalamic and archispinothalamic pathways start from the non-specific neurons present in laminae 4, 5, 6, and even few fibers from the 7 and 8. The neospinothalamic pathway fibers travel in lateral spinothalamic tract in the spinal cord and then in spinal lemniscus in the brainstem. Paleospinothalamic pathway fibers travel in lateral spinothalamic tract or in the spino-reticular tracts. Archispinothalamic pathways will travel in spino-reticular or spino-mesencephalic tract to reach either the reticular formation in the brainstem or the periaqueductal gray in the midbrain. From here, these second-order neuron fibers will project to ventral posterolateral nucleus of thalamus in case of neospinothalamic pathway, or to the intralaminar nuclei of thalamus in case of paleospinothalamic pathway, both to intralaminar and midline nuclei of thalamus in case of archispinothalamic pathway. The third-order neuron fibers will project to primary somatosensory cortex in case of neospinothalamic pathway, to frontal, cingulate and insular cortex in case of paleospinothalamic pathway, and to limbic lobe and collaterals to sending also collaterals to hypothalamus in case of archispinothalamic pathway. Neospinothalamic pathway is involved with rapid discriminative pain, whereas paleospinothalamic pathway is involved with arousal and attention associated with pain, as well as pain modification or modulation. Archispinothalamic pathway is involved in visceral, autonomic and emotional responses to pain. In addition to this ventrolateral system of pain pathways from spinal cord, there is also a dorsolateral spinothalamic tract. Here, the fibers starting from lamina 1 of one side cross to the opposite side and ascend in the contralateral tract of Lissor. Possibly presence of this tract is what gives relief of pain after dorsolateral cordotomy to the patients. The trigeminothalamic tracts will be similarly carrying information of pain from the head region. They will be dealt with brainstem videos. Now let us see which areas in the cerebral cortex are activated by pain sensation. The primary somatosensory area is involved in pain discrimination and modulation, and perhaps it's also involved in cognitive manipulation of pain. Posterior parietal cortex is involved with orientation and attention towards the painful stimulus. Cingulate cortex, which is located on the medial aspect of the cerebral hemisphere, is involved with affective component of pain, and following cingulectomy, usually the aggressive nature of the pain is lost. Dorsolateral prefrontal cortex helps in pain modulation through its connection with cingulate gyrus. Insula is involved in visceral responses to pain, and lesion to the insula results in asymbolia, wherein the unpleasant sensation associated with pain will be absent. And limbic lobes are involved with aversive response to pain. The input to the amygdala is involved with fear associated with pain. Now, pain modulation can occur within the spinal cord or through the supraspinal pain modulation pathways, or in the transmission through the spinothalamic pathways. In spinal cord, the segmental antinociception, which we learned with the earlier slide, is explained by gate control theory, which was first proposed by Malczek and Walls. The C fibers which carry the pain sensation stimulate the neurons in lamina 4. This allows the pain transmission in the spinothalamic tract. The inhibitory interneurons, which are located in the substantia gelatinosa, can generally inhibit transmission from lamina 4 by presynaptic inhibition. But these C fibers also send the collaterals to substantia gelatinosa that inhibit these inhibitory neurons. So the routine presynaptic inhibition done by the substantia gelatinosa neurons is disinhibited, resulting in bombardment of pain signals from the lamina 4 neurons. However, this channel can be gated by activating mechanoreceptors. Type A fibers, which carry signal from the mechanoreceptors, will again activate the neurons located in lamina 4. But they also stimulate the inhibitory interneurons, which are located in substantia gelatinosa by collaterals. So this results in presynaptic inhibition of information transmission. So although the neurons in lamina 4 are initially activated, further pain transmission will be blocked. This is the gate control theory. Coming to the supraspinal pain modulation, this works in a top-down fashion through ascending pain pathways like spinoreticcular, spinomesencephalic, and spinothalamic tracts. Spinal cord sends pain information to reticular formation, periaqueductal gray, and thalamus, which then project to cortex. Now, pain modulation occurs through descending pathways. Both the cerebral cortex and the hypothalamus project to periaqueductal gray, which then sends its inputs to the nucleus raphe magnus, which is located in medulla oblongata. From nucleus raphe magnus, the raphe-spinal tract descends bilaterally in the tracts of Lissor, and they terminate in substantia gelatinosa of Rolando neurons at all the levels. So stimulation of this tract produces generalized analgesia. Pain modulation can be brought in by altering the activity in spinothalamic tract. The spinothalamic tract activity can be inhibited by stimulating certain central structures like nucleus raphe magnus, periaqueductal gray, or ventral posterolateral nucleus in thalamus, or certain areas in the cerebral cortex like periventricular gray, primary sensory cortex, and posterior parietal cortex. Spinothalamic tract activity can also be inhibited by stimulating certain peripheral structures like peripheral nerves. Spinothalamic tract activity can be increased by stimulating medullary reticular formation, which includes other nuclei other than nucleus raphe magnus, as well as by stimulating primary motor cortex. These pain modulation pathways have enabled us to understand the pain mechanisms and also to devise methods to control pain. The spinal pain modulation through the segmental anti-nociception has not only made us understand the basis for relieving pain by rubbing the sore spot, but has also provided the basis for transcutaneous electrical nerve stimulus, that is, the buzzing sensation caused by small electrical shock given to the peripheral nerves provides relief from chronic pain in case of arthritis. In case of supraspinal pain modulation, a sharp localized pain stimulus can activate the diffuse noxious inhibitory controls in the brainstem, which are mediated by the nucleus raphe magnus and the serotonergic raphe-spinal tract, and this can result in generalized anesthesia or analgesia. This could be the basis for acupuncture or an older practice of branding the skin with hot metal rod to reduce the pain. That the periaqueductal gray matter can modulate pain through its input to nucleus raphe magnus has been utilized in what is called as stimulus-induced analgesia, so that an electrode placed in the periaqueductal gray allows the patient to stimulate the electrode as required to control his or her pain. Stress-induced analgesia is another interesting phenomenon. Routinely, the periaqueductal gray input to the nucleus raphe magnus is inhibited by the interneurons located in the periaqueductal gray. But the periaqueductal gray becomes disinhibited in times of stress by the opioid inputs from the hypothalamus. This forms the basis why the soldiers barely notice the injury in a battle, or the sportsman notice the injury during a game. Dorsolateral prefrontal cortex is an area amenable to suggestion, and this can activate the periaqueductal gray input to the nucleus raphe magnus through its connections with anterior cingulate cortex. This forms the basis for reduction of pain by using placebos and hypnosis. Then we have a question as to why do head and eyes turn towards the source of pain. This is because the spinothalamic tract fibers travel along with spinotectal tract fibers. The spinotectal tract fibers have a somatotopic projection in the superior colliculus. So once the information reaches the superior colliculus, spinovisual reflex is elicited, which will orient the eyes and head to the source of stimulus. and also when the pain information reaches the primary somatosensory area, where visual pathway will also be engaged, making us focus to the source of injury or source of pain. Let us look into certain terminology associated with pain. Sensitization is lowering the threshold of peripheral nociceptors. This is routinely brought on by histamine, prostaglandins, interleukin beta, and other factors which are released by tissue injury. So the sensitization will set in hyperalgesia, that is heightened sensation of pain, or allodynia, wherein a simple touch or a brushing sensation can also cause pain. Radicular pain is a localized pain in dermatome distribution. This is seen in case of disc prolapse or even herpes zoster. Referred pain is the visceral pain projected to somatic area, like myocardial pain to the medial border of the left arm and forearm, or gallbladder pain to the tip of the shoulder, etc. Radiating pain is a pain radiating along a vague area along the path of a nerve, classically described by sciatica. Neuropathic pain is a chronic stabbing or burning pain caused by injury to the peripheral nerves. Neuralgia is the severe pain in the distribution of spinal or cranial nerves, typically seen in case of trigeminal neuralgia, wherein one of the branches of trigeminal neuralgia, the skin supplied by one of the branches of trigeminal nerve, will be having a sharp shooting pain, which will be started by a whiff of air, or it could be even by simple touching. Thalamic pain is a chronic pain following lesion in the posterior thalamus. And phantom limb pain is a pain perceived by a body part that is no longer present. Like in case of post-amputation, although a person has lost a part of his limb, he can still perceive pain from that part of the limb. This could be because of, at the level of stump, the nerve fibers which are cut, they form the neuroma and there will be hyperactivity in the neuroma. Or it could be due to certain central mechanisms like sensitization of all central pathways which were carrying information from the amputated area. Or there is another central mechanism called as cortical reorganization. That is, those neurons which are located in the sensory homunculus of the postcentral gyrus, which were initially controlling or receiving the information from the amputated part, now they will reorganize to take care of some surrounding structure. So whenever the surrounding structure is stroked, that will be perceived as pain coming from the amputated part. Or simply the phantom limb pain can be because of psychological mechanisms. Thank you very much. Hope you enjoyed this video. You can visit the site for other such neuroanatomy videos. Thank you.